is Professor Ogawa from Kumamoto University in Japan. He will be giving the results of the LISTEN study. Professor Ogawa.
Slide. Escape?
Then you have to click your presentation. Here
Sorry. Thank you. Recent study, I presented a recent study. COI, recent study was funded by AstraZeneca. This is study design, but the background, the clinical benefit of to prevent cardiovascular events by using statins in hypercholesterolemic patients with diabetes has been demonstrated in several randomized studies. Recent data that statins were associated with an increased dose-dependent risk of new onset diabetes. However, few prospective randomized controlled trials have been conducted to investigate the impact of statin on glucose levels in patients with diabetes. This is a protocol. This recent study was a multi-center, open-label, randomized, parallel group comparative study. The target population was patients with diabetes, type 2 diabetes, hypercholesterolemia, over 20 years old, patients whose hemoglobin A1C was less than 7.4% during the 3 months prior to enrollment. Patient in this study was enrolled and randomly assigned to the rosuvastatin 5 mg or atorvastatin 10 mg group. The rosuvastatin group took 5 mg and atorvastatin took 10 mg once a day for 12 months. After randomization, usually every 1 month visits were scheduled as required by the study. The protocol laboratory tests were performed at 3, 6, 12 months. The diabetes treatment status were assessed by every visit. A total of 132 clinics and hospitals enrolled patients. This is lipid parameters, non-HDL cholesterol and LDL cholesterol. The changes in the lipid parameters from baseline to 12 months are shown in this slide. Non-HDL cholesterol, the primary endpoint, showed a reduction at 3 months in both groups, but however, there were no significant differences between the two groups. There was significant difference in the LDL cholesterol levels between the two groups for the overall study period using repeated measures ANOVA. The p-values was 0.039. Rosuvastatin reduced LDL cholesterol significantly compared with atorvastatin at 3 months by the unpaired t-test adjusted by Holmes method to avoid multiplicity at multiple comparisons. In the hemoglobin A1C level, the primary endpoint increased from baseline to 12 months in both groups. There were no significant differences between the two groups over the study period. However, there was a significant difference at 6 months after adjustment for multiple comparisons. In other words, hemoglobin A1C more increased in the atorvastatin group than in the rosuvastatin group at 6 months. There were no significant differences in the blood glucose levels between the two groups. And this is a cumulative incidence of diabetes treatment intensification. The cumulative incidence of intensification of diabetes treatment is shown during the study period. 45 patients in the rosuvastatin group and 64 patients in the atorvastatin group received additional drugs and intensified diabetic therapy. The hazard ratio was 1.46. There were no changes in hemoglobin A1C levels from baseline to 12 months between the two groups. However, there appeared to have a difference in glucose level effects based on the diabetes treatment decisions. That is, the patients with atorvastatin tended to change to more intensive therapy for diabetes. At 6 months, hemoglobin A1C levels were statistically significant, different between the two groups, and influence influenced physicians' behavior to change the intensity for treatment of diabetes, especially for the atorvastatin group. Consequently, the overall change in hemoglobin A1C did not reach statistically significant difference. However, our result suggests that rosuvastatin seemed to be preferable to be atorvastatin for this population. Conclusion. Rosuvastatin did not reduce non-HDL cholesterol compared with atorvastatin, but overall did reduce LDL significantly. The intensification of diabetes treatments was significantly less frequent in the rosuvastatin group than in the atorvastatin group. Further prospective studies are required to confirm the differences in the effect of diabetes among statins. Thank you for attention.
Thank you, Dr. Ogawa. This paper is open for discussion. Questions, please? Maybe I have Dr. Graham just comment on the issue of diabetes in statins in general.
Well, there is, of course, well-documented evidence of a modest increase in blood sugar, but of course, very often these are people who are heading that way anyway because they're overweight, and in general, the benefit of lowering LDL vastly outweighs the very small effect on blood sugar.
Do we have any additional questions? So Dr. Fox had to leave for another session. Any questions on the Signify trial, they can be referred to the ESC press office for an interview with an ESC